Give me 1 minute, sir, please. Good evening, friends. Thank you for joining this evening. The Dr. Professor Pranab from Calcutta is trying to join, but he has some challenges. We have invited faculty, Professor Ibrahim sir, Karnakaran sir. We have faculty HOD from KIMS Hubli, Dr. Guru Shantapa sir, and we have Professor S.K. Tiwari from IMS Varanasi, and our own senior faculty, Rajiv Sahay sir, Ajay Khanna sir, and other senior faculty and my dear students. We have two important cases for the day. Before that, I wish all the students well for the upcoming exams. Part of you have already finished and part of you are giving the exams in the coming week. So I wish you all the best for the examination on behalf of all the faculty here. And I wish the NEET SS is already on. The notification is sent. Both the INI super specialty as well as the NEET SS has been declared open. So I wish all the students take a note of it and start applying for the same at the earliest possible time. I wish all of you could take up any one of the super specialty of your choice. So this is the high time you don't take a break at all. You can definitely do your SRship and other things later. But this is a very important time of 2-3 months till September, so that you can sit, study at least 18 hours a day. I'm sure all of you will come out in flying colors. With that few words, I call this session open. And we have two important cases. One is kindly contributed by Professor Guru Shantapa sir, head of the department, KIMS Hubli. The girl is going to present a case on carcinoma of the buccal mucosa. The other candidate is kindly contributed by Professor Jailal sir. Naresh, he is going to present about neck swelling, secondaries of the neck. So today we have a head and neck session, and we have very eminent faculty here. Professor S.K. Tiwari sir from IMS Varanasi, and Professor Pranab Mandal sir from IPGMR, Professor Ibrahim sir, Professor Karnakaran sir from Madurai, both of them. Ibrahim sir also doubles up in Chennai also from Kaveri Hospital. Thank you, friends, for joining. Akshata will be presenting first. Akshata, good luck to you. Please introduce your unit chief, head of the department, and start your presentation. Can you share your PPT?
Yes, sir.
Dr. Naresh, are you with us? Okay, no problem. Please carry on, Dr. Akshata. Good luck to you.
Thank you, sir.
Go to the first slide, Kana.
Yes, sir.
Make it full screen. Yes, good luck to you. All the best.
Thank you, sir. Good evening, everybody. Today I'm going to discuss a case on carcinoma of buccal mucosa under the guidance of Dr. Guru Shantapa L. Kachin, sir, Professor and HOD, Department of General Surgery, KIMS Hubli. Myself, Dr. Akshata K. Gowda, postgraduate student, Department of General Surgery, KIMS Hubli. A 40-year-old male hailing from Bankapur, who was a manual laborer by occupation belonging to the low socioeconomic status. He presented with a complaint of ulcer over the left inner cheek since 2 months and swelling in the left upper neck since 1 month. Coming to the history of presenting illness, patient was apparently well 2 months back when he noticed a small ulcer in the left inner cheek, which was insidious in onset, initially of size 0.5 cross 0.5 centimeter, which rapidly progressed to attain the current size of 3 cross 2 centimeter. Initially, the pain ulcer was not associated with pain. Patient started complaining of pain since 3 days following an intervention, which is pricking type of pain, continuous, non-radiating, aggravates on oral intake and relieves with medications. Patient also complains of swelling in the left upper side of the neck since 1 month, which was insidious in onset, measuring 2 cross 2 centimeter, gradually progressive, not associated with any pain. Patient also gives history of bleeding from the ulcer while brushing teeth. He gives history of halitosis and excessive salivation. He also gives history of difficulty in chewing on left side. There's no history of decrease in mouth opening, no history of difficulty in swallowing, no history of trauma due to the sharp tooth, no history of loosening of the teeth, no history of white or red patch in the mouth prior to the lesions, no history of cough, no history of weight loss or loss of appetite, no history of fever. Coming to past history, there is no history of similar complaints in the past. There's no history of diabetes, hypertension, ischemic heart disease, bronchial asthma, or seizure disorder. Family history, there are no similar complaints in the family, no history of cancer-related deaths in the family. Coming to the personal history, patient consumes both vegetarian and non-vegetarian diet. This has a good appetite. The sleep is undisturbed. Bowel and bladder movements are normal and regular. Patient is a chronic tobacco chewer since 20 years. He discontinued since 1 month. He uses betel areca nuts slaked with lime and tobacco quid and places in the left cheek around 5 to 6 times a day. Each time used to keep it for 30 minutes. Is a chronic alcoholic since 20 years. Last pinch is 1 month back. Used to consume 1 pint of local alcohol every day in the night. Is a non-smoker. Coming to the summary, a 40-year-old male who is a chronic tobacco chewer and an alcoholic presented with a complaint of rapidly progressive, painless ulcer over the inner aspect of the left cheek with bleeding from the ulcer since 2 months, associated with halitosis and excessive salivation, and complaints of swelling in the left side of the neck since 1 month.
Dr. Akshata.
Yes, sir.
It's a 40-year male.
Yes, sir.
Is it? Is
Yes,
he a young person, or is it the common age for CA oral cavity?
Sir, 4th decade is the commonest age of CA buccal cavities.
So in younger patients, what history is important?
Sir, nasopharyngeal carcinomas can be common in the youngest age group, sir.
No. Have you taken history for HPV?
No history of sexually transmitted diseases, sir. Not
Where
mentioned.
have you written that? Not mentioned. So not mentioned means not asked. Okay. Okay. Have you asked about change in voice?
There's no history of change in voice, sir.
Have you asked for it? I can't see it. Anyway. Also, you've asked nothing about the tongue. Any deviation of tongue? Is he having difficulty in protrusion? Is there a slurring of speech?
No slurring of speech or no difficulty in the protrusion of the tongue, sir. No complaints of difficulty in swallowing also, sir.
No. Have you written this?
Yes, sir.
They've not written about change in voice or protrusion of tongue, right? Okay. So you said there is halitosis. Why is there halitosis?
Sir, in this condition, it may be because of the necrosis of the ulcer, which releases mercaptan and butyric acid and ammonia, sir. It can also be due to poor oral hygiene, sir. And due to the
because of the tumor and the oral hygiene.
Yes, sir.
Okay. You said he takes areca, he chews tobacco and takes areca nut.
Yes, sir.
So how does areca nut
Sir, aragonite
potentiate for
has a
vaccine.
component of alkaline and tannin, sir, where alkaline will stimulate the collagen proliferation, and tannin will help to stabilize the collagen fibers, sir.
So there is actually, this causes vasospasm and dysplastic changes, right?
Yes, sir.
Okay. Any history of any problem with his tooth? Any
There's
extraction
no history of loosening
loosening?
of teeth, no history of previous history of extraction of tooth, sir.
Right. Okay. And you said about pain.
Yes, sir.
Right. So why does he have pain? Is the malignant also painful?
Sir, in this case, the pain started after an intervention, sir. That is after taking edge biopsy, sir. But the chances may be due to infiltration of the nerve endings, or the ulcer will be
No.
having.
Why
Sir,
does the patient?
Sir, buccal mucosa will be sensory supply for the buccal mucosa will be by buccal
Did you
nerves.
ask about pain in the earache?
No radiating pain, sir. It's not radiating. No earache.
No, have you asked for it, or have you not?
Sir, I've asked for it, sir. Non-radiating
But
pain.
it's not mentioned there. It's not mentioned there. Is it important? Why can there be pain in the ear?
Sir, referred pain due to sir chorda tympani can involvement of the chorda tympani nerve.
Chorda tympani. Hang on.
Tongue.
Is it chorda tympani?
In this case, there is no
what is the function
related to the
of
tongue, sir.
I know there's no, but what is the cause of pain? If there was pain, which nerve gets involved to cause pain in the ear? It's the lingual nerve, and then through the mandibular, right?
Lingual nerve through the chorda tympani in the base of the.
Not chorda tympani. Chorda tympani is for taste. It's not a sensory nerve, right?
The lingual nerve.
Correct.
The lingual nerve.
Lingual nerve.
Right. Okay, sir, please, sir.
Akshita, am I audible?
Yes, sir.
The history of excessive salivation is present. Yes.
Yes, sir. History of excessive salivation may be due to chronic irritation, sir, or maybe due to exposed nerve endings over the ulcer, sir. And it can also be due to difficulty in swallowing the secretion, whichever is there. But he has not given history of difficulty in swallowing, so it can be due to chronic irritation or exposed nerve endings, sir.
Forgive me for interrupting. I have not at all asked that question at all.
Sir?
Just I have read the statement, history of excessive salivation from person. You started answering. You just get the question. Listen to the question.
Yes.
Okay. You are anxious, I think. Be a bit relaxed. Among the oral malignancies, in which organ the excessive salivation is more common? Why?
Sir, carcinoma tongue, base of the tongue due to the difficulty in swallowing, sir. There may be drooling of saliva because of that.
Yes. One is irritation, another one is difficulty in swallowing. So that is why. So the patient is not giving history of excessive salivation.
Yes.
But you are able to find out the patient is having excessive salivation. How can you find out?
Sorry, sir.
See, on taking history,
Yes, sir.
the patient does not give history of excessive salivation.
Yes, sir.
While examination, you are able to find out the patient is having excessive salivation. How? How can you find out that he is having excessive salivation?
Akshita,
yes, sir.
how will the patient present to you when he's having excessive salivation?
Sir, he will be
What
holding
we
a
need to
handkerchief to.
Yeah.
Right.
Patient goes on spitting every 5 minutes or 10 minutes, spitting in the answer cheek.
And Karshi.
When he do that, that means he has got excessive salivation, even though he does not give history of excessive salivation. Yes or no?
Yes, sir.
Yes, that's all from my
Akshita,
side.
Yes, sir.
Akshita,
Yes, sir.
how do you, which muscle
Yes, sir.
is involved to, which muscle protrudes the tongue out? Which is the muscle which protrudes the tongue out?
Genioglossus, sir.
Okay. So it's an extrinsic muscle or intrinsic muscle?
It's an extensive tongue muscle, sir.
Extrinsic.
See,
muscle.
why?
So if the intrinsic muscles were involved,
Yes.
how would what would the patient complain of?
It's not able to taut the muscles, sir.
Taut the
Tongue
muscle.
cannot
So-
be taut.
No, so what will the patient complain of if the intrinsic muscles involved? If you don't know, just tell
It's
me.
not
I'll
able to
let you know,
swallow.
okay? Yeah, swallowing and speech.
Speech.
There'll be slurring of speech,
Yes, sir.
right? Okay. You said there is no decrease in mouth opening.
Yes, sir.
How much is the normal mouth opening?
Sir, for incisor distance should be 4 centimeters, sir. We'll be able to insert for more than 3 fingers on mouth openings vertically.
Well, you shouldn't insert a finger inside that. Yeah, it should be about right. Okay. Any sir, please.
Dr. Akshita, am I audible?
Yes, sir.
So what is the condition known as decrease in mouth opening?
Trismus, sir.
Christmas?
Any other reason
So
for decrease in mouth opening?
Sir, infiltration into the pterygoids will cause trismus, sir.
Infiltration of the tumor?
Infiltration of pterygoid muscles.
Any other thing which
Much more
happens
common condition?
Sir, apart from this, there can be other causes also, sir. It can be due to inflammatory conditions. It can be
in this case.
in this case,
Is it-
infiltration of pterygoids
No,
will
that we heard.
cause.
Anything else? Any other reason for it? Akshita?
Temporomandibular joint involvement can also cause pet, which is less like
Anything else? More common, very commonly associated with these people.
temporomandibular joint involvement.
No, you think
Submucous fibrosis? Have you heard of SMA?
about anything
Yes,
about
yes,
submucous
sir.
fibrosis?
Yes, sir.
Akshita, do
That's
you
much
hear
more
me?
common, isn't it?
Hello?
Yes, sir.
You know what is oral submucosal fibrosis?
Yes, sir.
What does it cause? What
Sir,
will-
it
what
is
will
due to the fibrosis of the submucosal region, sir, which is a pre-malignant lesion due to the chronic irritation.
How does the patient present with the clinician?
Patient whitish bands over the oral mucosa, sir. Fibrotic bands can be seen.
You started your presentation with ulcer on the cheek.
Yes, sir.
So the patient came to the clinic with an ulcer, or did he come with some other problems? Some
He came with
sore
the
or-
ulcers.
He came with the latest stage ulcer,
Yes,
which
sir.
was bleeding. You told.
Yes, sir.
Okay. You have mentioned the ulcer to be on the cheek. Yeah. What's the
Yes,
subsite you have mentioned?
sir. Now
Location of
it
the
is
ulcer.
inner aspect of the cheek, sir, left cheek.
May I know what are the subsites in the oral cavity we discussed with the malignancy in oral cavity at a block now. So may
Yes.
I know what are the subsets of the oral cavity?
Sir, vestibule, sir, floor of the mouth, tongue, soft palate, and anterior pillars.
The entire tongue is a subset of the oral cavity.
No, sir. Anterior 2/3 is the part of the oral cavity, sir. Base of the tongue belongs to the oropharynx, sir.
So go again. We start from the vermilion and then describe the sites to be better.
Vestibule,
Lip doesn't come in the oral cavity.
lips, vestibule, floor of gingival ridges, floor
What
of
do you mean by the vestibule? It's the sulcus
Yes.
you want to tell.
Yes, sir. It is between
Labial
the-
and buccal.
Yes, sir.
And then the floor of the mouth.
Floor of the mouth. Anterior
And
2/3 of the tongue.
the soft palate.
Hard palate.
And have you heard about anything about the retromalar trigone?
Yes, sir.
Does it come in the oral cavity?
Yes, sir.
It comes in the oral cavity, isn't it?
Yes, sir.
Okay. Go on. You were there with the submucosal fibrosis. So is submucosal fibrosis a pre-malignant lesion or is it just
It's a pre-malignant lesion, sir.
any other pre-malignant lesions you know of in the oral cavity?
Erythroplakia and leukoplakia, sir. Chronic
Erythroplakia.
candidiasis. Erythroplakia and leukoplakia, sir.
Erythroplakia, you suspect of it to be a pre-malignant lesion?
Yes, sir.
Not really so. All
Akshita,
erythroplakia.
you said the patient consumes alcohol every day. So
Yes, sir.
what is the role of alcohol in cases of oral carcinoma?
Sir, it can act as a synergistic agent, sir. Alcohol causes vasodilation, which increases the absorption of the carcinogen from the tobacco and areca nut.
Anything else?
So it itself can act as a carcinogen.
It's a promoter. It's
Yes.
an irritant. It's a solvent, right?
Yes, sir.
So it's a promoter. It's an irritant. It's a solvent, and it suppresses DNA repair after exposure to nitrosamines and all. Okay.
Yes.
What about his diet? Have you asked about his diet?
Sir,
Anything
sorry,
to
sir.
do with diet? How is diet related to oral cancer?
Diet so certain diets like red meat and fast food will have a pro-inflammatory.
Not fast food. Okay, red meat and salted meat consumption, food dust, poor oral hygiene, right? What about herpes simplex? Any role? No?
No, sir.
Okay. So herpes simplex doesn't have. Okay. Can you name some genetic conditions which are associated with oral cavity malignancy?
Li-Fraumeni syndrome, Beta-Calicin syndrome, seropenic
Which one?
dysphagia. Sir,
No, go on. Let's just go on, please.
Li-Fraumeni syndrome, sir.
What did he say? Patterson. Li-Fraumeni.
Patterson.
No. Li-Fraumeni you can't put everywhere. It is not associated with this. It is Fanconi anemia. Fanconi's anemia. Okay?
Fanconi's anemia.
It's certain cancer. It affects basically it affects skin because of skin coloring. And ataxia telangiectasia here. Okay. So would you like to ask anything or should we go to examination?
Shall go to the
Okay,
examination.
Akshita, what do you think by history and dealing with?
Sir,
Akshita?
with a history of rapidly progressing painless lesion with is associated with the bleeding, halitosis, and excessive salivation, I would like to think about a malignant ulcer, sir.
No, for malignancy, he's got an ulcer, right, which is bleeding. That's the most important. Halitosis and all can be because of many other conditions. It's not prerequisite for halitosis to be there in malignancy, right? So he's got the risk factors. He's got an ulcer, and
Is
he's
it
got
chronic
symptoms
tobacco chewer?
suggested.
Is a chronic
Right.
tobacco chewer and an
So-
alcoholic?
Exactly. So he's got risk factors. He's got an ulcer, and he's got symptoms which are could be because of malignancy, isn't it?
Yes, sir.
Right. Okay. Should we go to the examination?
Akshita,
Yes,
what
please.
are the various viruses which are associated with the oral cancer?
HPV, sir, human papilloma virus,
Yes.
and for nasopharyngeal, Epstein-Barr virus can cause, sir.
Right.
Syphilis can also cause.
Right. Syphilis is a virus?
Syphilitic tonsillitis. No, sir.
Is it a virus?
No, sir.
Hmm.
Bacterial. Virus.
Look, Akshita, you can't look for help. That's wrong. You can't have someone sitting next to you prompting you. That's wrong. Okay? You may not know the answer. That's fine with us. We'll tell you the answer. But seeking help from someone sitting next to you is not acceptable. Okay, Akshita?
Yes, sir.
Do you get me? Yeah. Just do away with that.
Akshita, when you say viral oral papilloma virus, is there any change in the outcome or in the way in which is the cancer is manifesting when it is due to the papilloma virus? No, somebody who is getting the carcinoma because of the papilloma virus, and
Yes,
someone
sir.
who is getting not because of that, is there any change in the histology, change in the outcome, change in the prognosis?
I'm not sure, sir.
Okay, it is significantly important because now we classically differentiate if it associated with the papilloma virus, especially in esophageal carcinomas and all. Most of the time it will be non-keratinized, and we firmly believe keratinized is the hallmark of squamous cell carcinoma. Papilloma virus will be a non-keratinized carcinoma. So now the more understanding is there. The treatment is also, it is better prognosis. So that is also important. Not only you do the histology and histopathology and say it is squamous cell carcinoma, you have to find out, and possibility if there is associated with papilloma virus is also important in diagnosis.
HPV more common occurs in the oropharyngeal region rather than as the oral jet, more common in the oropharyngeal region. The stage may be advanced, but the prognosis is better if it is associated with HPV. Now tell what is field cancerization?
Sir, the entire oral cavity will be exposed to the similar carcinogen as the lesion, sir.
Yes.
So the entire oral cavity has the chance, same chance as the lesion to acquire the condition, sir.
So what is the chance of having the synchronous cancer and the metachronous cancer in the oral cavity?
Sure, sir.
Is it only in the oral cavity, GI tract, field cancerization? Can it involve any other field?
For this risk factor, it is GIT, sir.
The smoking is a risk factor only for the GI tract.
Nasopharyngeal.
What are the mucosa exposed to the smoke?
Think and answer. It is very common question. No? You are right in
Cavity
saying
can
it's a
also
common.
be.
Yeah.
Nasal cavity can also be exposed to the smoke.
And the nasal cavity is exposed, respiratory tract can be exposed.
Respiratory tract.
Do you know if any
In the
fungal infection
smoking-
may make for this here?
Sorry, sir.
Do you know of any
Not here,
fungal
sir.
infection? Do you hear me? You hear me, Akshita?
Yes, sir.
Do you know if it is fungal infection of the oral cavity which may mimic as a malignancy or masquerade?
No, sir. I don't know, sir.
You heard of histoplasmosis?
Yes, sir.
It may masquerade as a the presentation the infection may say that it will be look like to be a presence of that. Okay, proceed.
Candida infection. No? Candida is one of the very important infection which is there. Fungal infection which is there. Okay, Candida.
Another common is a rhinosporidium that can also present hidden areas, present with the bleeding, epistaxis, all that problem. What do you think can be also there?
Yes, sir.
Actually, smoking is a very important cause for the oral cancer. So you
Yes,
don't know what is the meaning of pack here?
Sir, if a patient consumes 1 pack of cigarette for each day for a year, it does 1 pack here, sir.
This 1 pack contains how many cigarettes? How many cigarettes are there considered for the 1 pack?
10.
It's 20, you know?
Yes.
20 cigarettes.
Yes.
Right.
Is there is a difference between filter cigarette and non-filter cigarette?
The risk will be more in the non-filtered cigarettes. The carcinogen.
In a filter cigarette, only 15% of the smoke goes to the lung, 85% goes to the surrounding area.
Yes.
I think you can go on the examination now. You know, it's already 35 minutes. Go on the examination part now.
Yes, sir. Coming to the general physical examination, a middle-aged male who is moderately built and nourished, conscious, cooperative, well-oriented to time, place, and person, belongs to the ECG score of 1. His height is 157 centimeter, weight is 50 kg, the BMI of 18.3 kg per meter square. A tender swelling measuring 1 × 1 centimeter noted, which is 0.5 centimeter below the left commissure. There is no pallor, icterus, clubbing, cyanosis, or edema. Cervical lymph nodes are enlarged, which will be explained in the local examination. Patient's pulse rate is 70 beats per minute, measured in the right radial artery, which is normal in volume and regular rhythm. Blood pressure is 120 by 70 millimeters of mercury, measured in the right brachial artery. Respiratory rate is 16 cycles per minute. Come to the local examination. Patient was examined a well-lit area with adequate exposure with due prior consent. On inspection, there is a fullness noted in the left cheek and the angle of the mandible. An nodule measuring 1 × 1 centimeter noted, 0.5 centimeter below the left angle of the mouth, 1 centimeter from the midline, which has well-defined borders. Overlying skin appears erythematous and smooth with no discharge. Mouth opening is inadequate. There is halitosis with poor oral hygiene noted with nicotine stains of teeth. Sharp mandibular canine teeth was noted on the left side. An irregular solitary ulcer in the left buccal mucosa measuring 6 × 2 centimeter, extending 3 centimeter from the upper gingivobuccal sulcus till the lower gingivobuccal sulcus vertically, and horizontally from the retromolar trigon posteriorly till the left angle of the mouth anteriorly, abutting the gingiva of canine, first and second premolars medially with well-defined margins, everted edges, and unhealthy tissue in the floor. The bleeding from the ulcer is noted. Rest of the buccal mucosa, floor of the mouth, tongue, tonsillar pillars, uvula, hard palate, posterior phalangeal wall, lips appears normal. Upper gingivobuccal sulcus is free. Lower gingivobuccal sulcus could not be made out separately. No leukoplakia or erythroplakia seen in the oral cavity. No missing teeth. On palpation, a tender nodule measuring 1 × 1 centimeter noted, 0.5 centimeter below the left angle of the mouth, which is 1 centimeter from the midline with well-defined borders, smooth surface, firm in consistency, immobile with overlying skin not pinchable. Surrounding skin is indurated 2 centimeter all around. There is no discharge from the nodule noted. An irregular solitary ulcer in the left buccal mucosa measuring 6 × 2 centimeter, extending 3 centimeter from the upper gingivobuccal sulcus till the lower gingivobuccal sulcus vertically and horizontally from retromolar trigone posteriorly till the left angle of the mouth anteriorly, abutting the gingiva at canine first and second premolars medially with well-defined margins, everted edges, unhealthy tissue in the floor, and induration extending 1 centimeter superiorly and all around and the indurated edges with indurated base noted. The ulcer bleeds on touch. The upper gingivobuccal sulcus was free. No lower gingivobuccal sulcus could not be made out separately. No other palpable lesions in the oral cavity. Rest of the buccal mucosa, floor of the mouth, tongue, tonsillar pillars, uvula, hard palate, soft palate, lips appear normal. On bidigital examination, mandible appears normal. Sensations are normal. On bidigital examination, there is no induration noted in the skin over the ulcer area. Coming to the examination of the neck, a palpable solitary lymph node in the submental region towards the left measuring 2 × 2 centimeter, which is non-tender, mobile and hard in consistency, and palpable single lymph node in the left submandibular region measuring 4 × 4 centimeter on the left side, which is non-tender, fixed and hard in consistency. Coming to the systemic examination, respiratory system examination, normal vesicular breath sounds heard, no added sounds. On parabdominal examination, soft, non-tender, no organomegaly and bowel sounds were heard. Cardiovascular system, so first and second heart sounds were heard and no murmur. Central nervous system examination, higher mental functions normal with no focal neurological deficits. Summary. A 40-year-old male who was a chronic tobacco chewer and an alcoholic presented with the complaints of rapidly progressive painless ulcer over the inner aspect of the left cheek since 2 months, associated with halitosis, spontaneous bleeding, and excessive salivation with difficulty in chewing on the left side, with all complaints of painless swelling over the left side of the neck since 1 month. On examination, a tender ulcerative lesion measuring 6 × 2 centimeter with irregular indurated margins with everted edges and pain granulation tissue in the floor with indurated base and induration of the surrounding tissue extending 1 centimeter all around, and the ulcer bleeds on touch, and a non-tender mobile hard lymph nodes palpable in the left submandibular region and a non-tender fixed hard lymph node noted in the left submandibular region. Provisional diagnosis, locally advanced carcinoma buccal mucosa, stage being T4A, N2B, M0.
Akshata, in the general local examination, you mentioned the skin is not indurated, but in the summary final thing, you mentioned it as indurated. Can you just verify it?
Sir, induration around the nodule is noted, sir. Which was, there is a nodule in the chin, sir, towards the left side, which is 0.5 centimeter below the lips, left commissure, which is fixed, sir. The skin around the nodule is indurated, sir.
So there is an ulcer and also a nodule. Two
Yes,
things.
sir.
You also said ulcer is base is indurated, edge is indurated. What do you mean by that?
Edges are everted, sir.
No. One area you have put as the edges, base and the edges are indurated.
Can you go to the summary? It's mentioned in summary like that. Yeah.
Everted edges. Indurated base.
In the previously when we are saying that, second you said that this ulcer is bleeding but pale granulation tissue. So what do you mean by that pale granulation tissue?
At the center, there is a unhealthy tissue, sir.
Unhealthy is different, pale is different. No?
Pale tissue was noted at the center of the ulcer, sir. Surrounding there was a bleeding. Only at the center of the ulcer, there is a pale tissue, sir.
Is it that scab or pus or the floor is covered with the slough?
Sir, at the center of the at the center of the ulcer, there is a pale unhealthy tissue, sir.
Be careful because it's quite unusual when you are saying such an active ulcer bleeding. and putting as a pale granulation tissue. Usually it's unhealthy tissue, it's a cold granulation tissue. Need not be pale in color. It will be always, color will be always, it is only a cold granulation tissue, overhanging the margin. Normally, and such a ulcero-proliferative lesion will not have a pale ulcer in the middle.
Yes.
If it is there,
Usually
it's fine.
malignant ulcers will be very vascular. So
Vascular.
there will be neovascularization. So you don't expect a pale granulation tissue. Pale granulation tissue can be seen in chronic ulcer, chronic non-healing ulcers, arterial ulcers. So this you are going to present as a malignant ulcer. You have to put the correct terminology.
Because it is ulcero-proliferative lesion impaired, and edges, because it's important because we have put as a edges also indurated. That what we are interested is whether the induration at the base is extending beyond the margin. Because once you are setting the margin free,
Yes, sir. 1
to the-
centimeter all around.
yeah, that is fine. When you say it is beyond the base, it is extending, that will be important because it's to decide on the margin disorder. Can you go to that general examination slide, sir? Next. Somewhere you have put us. General examination, previous slide. Blood pressure. Why do you want to put this patient under ECOG 1?
Sir, is able to carry out the activities, sir, only with restricted daily activity.
What is the restriction? Yes.
Sir, is not, he was a manual laborer before, sir. Is not able to do 50% of his work.
Okay.
Okay. Lakshita, go to the next general examination slide. What is that blood pressure in right brachial artery by auscultatory method?
That is what I wanted to ask.
What is that by auscultatory method? It is specifically written by auscultatory method. That's what I wanted to know. Okay, tell what are the various ways to take the blood pressure?
Sir, initially we'll do palpatory method, sir. If any hypertensive is there, the chorus of sounds will be missed. So then we'll go for auscultatory method, sir. First we'll do palpatory method and then we'll confirm it with auscultatory method, sir.
So
We will not do with the Doppler
you can
method?
find both systolic and the diastolic blood pressure.
Auscultatory will find both systolic and diastolic, sir.
So need not to mention about that, isn't?
Look, Akshita, this is inviting trouble.
Yeah.
Just inviting trouble. Just say normally. Do you write normally by auscultatory? You don't write. You just write blood pressure so much.
Yes.
Blood pressure, pulse so much. Right? Don't invite trouble.
Yes. Sorry.
Akshita,
Yes, sir.
there are lots of gaps in your examination. Right?
Sorry, sir.
There are lots of gaps in your examination. You have not mentioned anything about the movement of the tongue, whether the tongue, there's any deviation of the tongue,
Sir,
or can the tongue
As
come
there
out?
was no symptoms of difficulty swallowing.
No,
there was
swallowing
no
and movement
base
of tongue
the
are two different things. Akshita, swallowing and movement and protrusion of tongue are different things, right? You've not, have you mentioned the RTM, retromandibular trigon?
Sir, the ulcer is extending from the retromolar trigon, sir.
So it is affected. Then have you examined the TM joint?
TM joint coming. No, sir.
Right. So there are things. Have you palpated the mandible completely?
Yes, sir. By digital examination, I mentioned, sir.
So this, right. Okay.
You have said excessive salivation, but no
Yes.
difficulty in swallowing. Then why there is excessive salivation?
Sir, exposed nerve endings, sir, due to chronic irritation. He
Okay,
has
that
a
will
sharp
normally-
canine tooth, sir, on the
That
left side.
already, see, when there is more saliva, you will always swallow it. How do you come to a conclusion there is excessive salivation?
Look, Rakshita, there has to be some amount of difficulty in swallowing. There has to be something. If the retromandibular trigon is involved, There has to be some. It can't be just that the patient will
There
have normal
has to
swallowing.
be some amount of difficulty in
Right.
opening the mouth if the RLT is involved.
There'll be some difficulty in opening the mouth. It can't be normal.
Yes, if the RLT is involved, there will be difficulty in opening the mouth, and there are some extensive, as you are telling, from the RLT to the angle of mouth. So it's a huge area involved. And you have also told that all the teeth are intact. You have not mentioned either in the history or in the examination, is there any history of loosening of the teeth?
No
The
history of
teeth may
loosening
be
teeth.
intact. No
One-
history.
No history,
And
sir. Mentioned in
Tooth formula also you have to write.
Yes.
Any difference in the
So-
speech? Difficulty in the speech?
The patient gives no history, sir.
No, see, you are explaining such a big ulcer with the angle, there is a nodule, induration, tetramandibular. You still feel there is a voice will be the same, articulation will be the same, patient will not have a difficulty.
Patient will be having difficulty, sir, but patient didn't give the complaints of change in voice.
He'll not complain, but can you examine? Can you examine whether he is able to swallow properly? Can you examine whether his speech is slurred? Can you examine whether his tongue is moving normally? You can.
That is very important part of examination.
Is his palate moving normally? Is the palate moving properly? Have you? How do you know what is Malampattu grading? Can you see the posterior pharynx on opening the mouth?
Posterior pharynx was not visible, sir. Anterior pillar
Yeah.
and base of the tongue
Right.
was.
So it's Malampattu. Then it's not complete opening now. Akshita, you have to put in a bit of effort on this, right?
These are not matching actually. The growth extending from RMT till the angle of mouth, there is a halitosis of the patient, and everywhere is indurated. And now you tell there is no slurring, no dimpling, and the patient has no difficulty. It's not matching actually. Okay. And in the TNM staging, you have straightaway written it to a T4 tumor. How do you justify it?
Yeah, T4B, how do you, T4, no? How do you justify?
Sir, on examination, the mouth opening was not adequate, sir. So trismus,
So you write it T4.
sir, written T4A, skin involvement. The nodule is.
You kindly enlighten us what is T4 lesion in a case of CA oral cavity.
So T4 lesion is any lesion which is more than 4 centimeter with involvement of the adjacent structures is T4A, sir. Like mandible, maxilla, cortical structure, and skin.
Yeah. Only the length of the more than 4 centimeters is not enough. You have to mention how do you tell it to be T4 and N2B you have written. Why is T4A?
Because there is involvement of the skin, sir.
No,
Skin is
what way
involved.
there is involvement of the skin?
So the nodule which was present on the chin, sir, it is fixed.
Why not it is just an
And there's
induration? Why not it is an induration? You said
Is
there
the
is a
nodule
induration,
in-
which is continuing with ulcer induration.
Is the nodule in continuity with the ulcer or able to
Yes, sir.
palpate both together?
Yes, sir.
So what Sir is asking is why not that induration, maybe the continuity of the ulcer induration itself? How will you justify that it is a separate nodule? It is like a satellite nodule.
Sir, there is continuity between the inside of the ulcer, the
So it is a part of an ulcer.
anterior part of.
So are
The
you going to
skin
say
has
that
not The skin has not ulcerated, no? It's not a through and through region.
It's not a fistula, but the skin is involved, is it, Akshita?
Yes, sir.
Akshita?
no,
Right, it's not a
nodule is seen
fistula.
externally or internally?
Nodule is outside, sir, external, sir.
So when you move the nodule, does the ulcer move?
So nodule is fixed, sir. It's not mobile.
Skin is also fixed.
Yes,
Fixed
sir.
to what? What is it fixed to? What is it fixed to? The buccal cavity, is it? The buccal skin?
Yes, sir. Below that
No,
nodule, you
is
can't see the.
Look, Akshita, I want to know whether the ulcer is in continuation with the nodule. Or is there a distance between, is there a gap between them? Can you move the ulcer over the nodule? Is the ulcer
Yes.
mobile?
No, sir.
Do the two move together?
No, sir.
They move separately.
Sir,
So
the ulcer and the
nodule,
nodule,
so the nodule is different from the ulcer.
sir, the ulcer base is indurated, sir. We can't move the ulcer, and it is in the continuity of the ulcer because it is.
Akshita,
Yes,
I
sir.
want to know whether the ulcer and the nodule are one entity or are they different entities?
They are same, sir.
They're same, no?
It's in continuity, yes, sir.
Then continue. So when you move the nodule, the ulcer should also move.
Sir, it is not mobile, sir.
Oh, it may not be mana. If there's a nodule and there's an ulcer on the inside, when I move the nodule, the ulcer will move. Won't it?
Can you show the photograph?
Okay,
Can you show
forget
the
it.
photograph of the one?
Yeah, just show us the photograph. Just enlarge it. Let me have a look. Okay, why is it important to know whether the nodule is in continuity with ulcer?
Where is it, Ma?
Photograph of the nodule.
She doesn't have a photograph of the nodule, I think.
Yes.
She's just got a picture from inside. But there. But you just enlarge that. So there's just it's just a lump. It's not a nodule. I think the whole thing is the whole thing
doesn't looks like a
just
nodule.
tended,
It is
just waiting to burst out.
Sir, from
It's just waiting to burst out.
okay. So if you are convinced, it's different, Amma, but be careful in that when you are committing that as a skin involvement.
Okay.
Be sure.
If it is different, Akshita, if it is different, how do you explain the nodule? It's a second tumor.
Yeah.
Akshita, are you
Yes,
there?
sir. Yes, sir.
So what is the second? What is this nodule? How do you explain the nodule? What do you think this nodule is then? If it is not related to the ulcer.
It can be second time.
Hello.
It can be second time.
It can be a second tumor.
Yes, sir. Second time.
Don't stretch your imagination. Second
Okay, where is this tumor arising from then? Where is this tumor arising from? If it is different, you mean the inside of the buccal mucosa is intact underneath the tumor? So what is this tumor now? Akshita, it would be very
This nodule is sitting right over the ulcer. If you see the anterior part of that, so you cannot explain it by the two pathologies there. Okay, it's the same pathology there, and there is extension of the induration is there. That is the way you have to explain that, rather than saying it's the two pathologies are there. Okay, if you see the anterior margin of the ulcer, it is coming right up to the angle of the mouth, and at the same place there is the induration is there. You can see the bulge outside there.
Yes, sir.
So it is the same induration which is continuing in that. So both are the same things. Okay, it is not the two different things. It is the same thing which is there. Okay.
Yes.
Because that is the only way you can explain that.
That's why you're calling it T4A, because the skin is involved. Otherwise, the ulcer would not be T4 because you're saying that is a different tumor. If it is T4 and you're saying that the skin is involved, then obviously, otherwise you would say, well, why would you T4 if the nodule is different? So it is best to think of one pathology. Okay.
Yes.
So
And is it N2B? Are you correct in assigning it? Please justify.
Sir, N2B because the sides of the submandibular lymph node is 4 centimeters, which is more than 3 centimeters, and multiple nodules. Two lymph nodes are involved. So,
Right? It's more than 3, not more than 6. That's what you want to
3 to
tell?
6. Yes, sir. 3 to 6 and multiple, and submental and submandibular.
no, N2B is what? Akshita, what is N2B?
N2B is
oral cancer.
multiple lymph nodes of measuring 3 to 6 centimeters. Sir.
Multiple ipsilateral lymph nodes.
Ipsilaterals.
Right. None more than 6 centimeters. Okay.
Yes.
So there are 3 things. They're multiple, they're on one side, and none are greater than 6 centimeters. There are 3 things for N2B.
Okay.
Okay.
Okay, how will you
proceed now
proceed?
further? Yeah, it's already 9 o'clock, isn't it?
Yeah. Next case.
No.
The next case.
Just
Move
tell
on to
how.
the
We'll just wait.
investigation.
Yeah.
We'll finish off fast. Akshita, are you
Yes,
there?
sir.
Yeah.
Yeah, but okay, how will
Proceed
you
with your
proceed now?
management. Yeah.
Sir, first I'll confirm the case with the biopsy, sir, H biopsy. Then to confirm the
Okay. It comes out to be
notes, I'll
squamous
take-
cell carcinoma, grade
Yeah.
3.
Go ahead.
Go ahead.
Yes, sir. To confirm lymph node, whether it is metastasis, I'll go with the FNAC of the lymph node, sir. And to look for the involvement of the bones and again lymph node status, I'll go with the CT. And then to look for soft tissue involvement and any perineural spread, I like to go with the MRI, sir.
Okay, Akshita, I tell you that this lymph node is because of infection.
Yes, sir.
How will you disapprove my statement?
Sir, if infective pathology, lymph node will be tender, sir. But
Okay,
here,
what
in this case, it is non-tender and no signs of inflammation, sir.
Your node is
inflammation?
more
Why?
than 2
Local
centimeter.
temperature
Your,
tenderness.
your node is more than 2 centimeter. Your node is fixed. That should be the reason you should put, not the tenderness. Tenderness can be there in any.
Yes. It will be soft. It will not be fixed. It'll be if you give a course of and it will come down, right?
Even a malignant node can become tender if it starts infiltrating the surrounding nerves.
Yes. Tenderness is not a contraindication.
So tenderness is not one. Okay, so have you got your biopsy report with you?
Sir, biopsy report is awaited, sir. I have FNAC report of the nodule and the lymph node, sir, which
Okay,
gives it as a
pull it
well
up.
differentiated.
No, can I see?
Yes, sir.
Just
The
make it
swelling in the
smaller,
chin
please.
below the left commissure shows proteinaceous background with inflammatory cells with atypical cell armistice in single line clusters and features suggestive of well-differentiated squamous cell carcinoma. Sir. In the lymph nodes of the submandibular and submental region shows round polyhedral cells arranged in sheets and singles with the large hypochromatic nucleus. With background shows abundant hemorrhage and few lymphoid cells suggestive of well-differentiated squamous cell carcinoma.
When clinically the chin nodule is in continuity with the ulcer, it is better not to do an FNAC there. What happens is it will promote a orocutaneous fistula.
Yeah, you are inducing that, giving way for the orocutaneous fistula to develop.
So already patient has developed pain after some intervention, he told. So there is a possibility is also very close to the commissure. Even the reconstruction will become difficult later.
Okay, Akshita, why don't you want a oral
Jailal, sir.
Yes, sir.
Sir, she meant FNAC of the node, not the lesion. Submandibular node.
No, she said separately she taken a biopsy from that nodule outside.
No, biopsy from the ulcer, FNAC from the node. Biopsy report is awaited and the FNAC report of the node is deposits.
Okay, sir. Okay, sir.
Okay.
Okay, Akshita.
Yes, sir.
What is the importance of an oral cutaneous fistula?
Sir, if there is a orocutaneous fistula, there'll be drooling of the saliva from the fistula, sir. It will be
right. So removing that whole portion, if the skin is involved, reconstruction, excision, and reconstruction becomes a problem. And the patient's lifestyle, till surgery happens, his lifestyle his life is hell, isn't it? All that food material all will be coming out of getting stuck. Okay, how do you take a CT? Anything to important while procedure? Any maneuver to be done while doing a CT?
Sir, I could not hear, sir.
When you're doing a CCT of this patient? will you ask the patient to do some maneuver while doing a CT?
Puff cheek.
Something you'll be, yes, you'll ask her for a puff cheek. Why do you want that?
Sir, we want to differentiate the structures separately, sir. Is that
Right, because if this thing, it becomes difficult for the radiologist to see the various structures.
You prefer to do MRI or only CT is enough for you?
MRI? I'll go with MRI to look for the soft tissue involvement and perineal invasion and base of skull. So,
The MRI will give you any value on the mandible?
sir, mandible, the inferior alveolar nerve will be entering through the mandibular foramen and coming out of the mental foramen, sir, to look for the involvement of the nerve.
And medullary involvement is also more with the MRI.
Yes, sir.
Okay, Akshita, why can't you do a CT for a medullary involvement of the bone? Why do you have to do an MRI? I can do a CT. CT is good for bone.
But the bone marrow,
Because
MRI business.
yeah, very good, very good. Bone marrow is
Sense
in adult bone marrow is replaced by fat.
Yes.
Right? It's replaced by fat. So CT is not very good here. That's why you got to get an MR done. Right?
So, according to you, it is an operable or inoperable? No? So 4 years, you said.
Yes, sir.
So when you say it is
Before that,
inoperable.
sir, what about the role of PET scan? Any role of PET scan?
Sir, as it is a loco-regional spread,
Good.
PET scan is not indicated. It does not hematogenous spread. No meds, sir.
So you'll only do it if you plan to do, right, if you want to plan to do any adjuvant treatment, then you may get a PET scan. That's you answer. Is it operable? What do you plan for this
we
patient?
can go with wide local excision and then adjuvant RT can be given, sir.
When you say it is inoperable.
Sir, if there is a T4B, it is well advanced, like involving the pterygoids base of the skull, it cannot be operated. At that time, we'll go with a neoadjuvant RT.
Your case, you said it is a retromolar trigon is involved, no? What is the fate of a lesion in the retromolar trigon?
Sorry, sir?
What will be the effect of some lesion in the retromolar trigon? What your fear of that?
Sir, it can extend to the infratemporal fossa and go to the base of the skull, sir. It will be very aggressive once it involves the retromolar trigon, sir.
So your patient is having a retromolar trigon extension, no? It is there.
Also reaches till extramolar trigon, sir.
Okay.
So the treatment is a wide local excision. What about the nodes?
Wide local excision with the hemimandibulectomy with modified radical neck dissection, sir. Type 1.
Why do you want to remove the mandible? Clinically, the mandible is not involved.
So, but
is the mandible involved in your investigation?
Sir, the nodule and the sir, OPG can be done to look for the involvement of the mandibles too.
Already you have done CT now.
CT is done. MRI is also done. Mandible is not at all involved. So what's your plan? Is there any change in your plan, or you want to go ahead with the same thing?
Sir, but the ulcer is abutting the mandible, sir.
So why not you do the marginal mandibulectomy instead of hemimandibulectomy?
Yeah, exactly.
So what is the difference between marginal and hemimandibulectomy?
Sir, in the marginal mandibulectomy with the ulceration, we will take off the part of the mandible, sir. Whereas in the hemimandibulectomy, we'll take from the mental foramina till the angle of the mandible will remove the mandible from enter half of the mandible, sir.
In other words,
one side of the
mandibulectomy, you maintain the inferior border of the mandible. So that's more important. So can that be done in this patient? or for whom it can be done? For an elderly patient, young patient?
Sir, if the ulcer is more than 1 centimeter from the mandible.
No, you didn't
There is
understand my question. For which patient, elderly patient or younger patient, marginal mandibulectomy can be done? For which patients?
Sure, sir.
So in elderly patients, there will be mandibular resorption. The alveolar margin gets resorbed. So you cannot do a marginal mandibulectomy. So for younger patients, you can do. So if the clinical features and investigations doesn't show any mandibular involvement, you can do a marginal mandibulectomy for the sake of margin alone. Need not sacrifice the entire mandible. And how would you like to reconstruct?
Is involved, it is difficult.
So how would you like to reconstruct it?
Sir, it can be, we can use titanium plates, sir. Along with, apart from that, we can use the flaps like a free fibular flap from the ribs we can take, and iliac crest also we can take, sir. And osteocutaneous flap from radial, free radial flap, free radial osteocutaneous flap can be taken, sir.
Usually free radial is a soft tissue flap only, not an osteocutaneous. Fibula is a osteocutaneous.
Fibula.
Free fibula, okay?
Yes.
So in the neck dissection, you told about modified radical neck dissection. So what are the lymph nodes will be removed?
It is a fixed node, no? Will you go for modified reduction immediately or with after new?
After giving radiations. After giving neoadjuvant after giving chemo radiation to downstage the disease, and then we'll go for modified.
It will downstage the stage. After radiation, will you downstage or your size is reduced?
Size is reduced.
Stage is not going to change.
So if you are planning to do any neoadjuvant therapy before surgery, it is ideal to do a PET scan. So that's what sir was asking you in the initial thing. Yes. So whenever you are going for an upfront surgery, you can do with MRI and PET scan, MRI and CT scan. But whenever you are looking for a neoadjuvant, it can be radiation or a chemotherapy or any kind of therapy. It's better to go with the neoadjuvant whole body PET scan. Yes. Because sometimes in progressive disease, new lesions may appear. So we don't know whether it's a missed lesion or a new lesion appearing. So it's always medico-legally important to document it with a whole body PET scan prior to the neoadjuvant therapy. So sir was asking about these fixed nodes. So in fixed nodes, you are going to do a neoadjuvant therapy. So once the neoadjuvant therapy is done, the nodes become mobile. So what is your dissection? It's going to be a modified radical neck dissection or a radical neck dissection?
So once it is mobile, we can go with modified radical neck dissection.
So if clinically the node is fixed, whether you give a neoadjuvant therapy or not, even if the node becomes mobile also, again you have to do a radical neck dissection only. There is no role of modified radical neck dissection. So what are the structures you remove in radical and modified radical neck dissection? Can you just enumerate the structures alone?
Sir, in the radical neck dissection, we are going to remove level 1 to level 5 lymph nodes, sir, along with the sternocleidomastoid, spinal accessory nerve, internal jugular nerve, and submandibular gland, and lower part of the parotid gland, sir. Whereas in case of modified radical neck dissection, we have 3 types again, sir, based on what structures we are going to spare. In the modified radical neck dissection type 1, we are going to spare the spinal accessory nerve. Along level 1 to level 5 will remove, sir. In modified radical neck dissection type 2, we are going to spare sternocleidomastoid and spinal accessory nerve, sir. In
the functional neck node dissection,
so type 3 is functional neck node dissection, sir.
There is no difference between functional and modified type 3. Both are same. What group of nodes you removed in functional neck node dissection? When you do for thyroid, you do the functional neck node dissection. What are the groups you remove?
In the thyroid, we are going to remove the level 6 lymph nodes, sir, and 2, 3, 4.
Which group
not
you
remove
are
the
not
level one.
going to?
It's in central neck node dissection, we are going to remove the level.
Central is different.
See,
When you say the
Akshata,
functional neck node dissection, it does not include the level 1 node.
See,
But when you are
Akshata,
saying modified type 3, you are still going to remove the level 1 to level 5.
see, Akshata,
Sir,
Akshata, the chart says you don't have to remove level 1 node in functional neck dissection. Whereas in type 3, you have to remove level 1 lymph node. That is the difference between functional neck dissection and type 3 neck dissection. Got it?
yes, sir.
Yes.
So Akshata, only one question. So the nodes are there in the submandibular and submental alone. So why do you want to remove all other nodes up to level 5? Why don't you remove just level 1 and level 2 alone along with the mandible? Why do you want to remove other nodes?
As it is an aggressive tumor, there can be micrometastasis to the other nodes as well, sir.
No, if it is
It's
not
only
an aggressive
fine.
tumor, it's a well differentiated tumor, 1 centimeter only.
And I will sorry sending the message
Once
to
the
close.
node is positive and it is multiple, we'll go with the modified radical neck dissections.
So occult metastasis and skip metastasis are very common in oral cavity. So it will not follow the rules. Okay, it can go to any nodes. Even a single node in the level 5 can be there. So which may not be even palpable also. So ideally, we have to always remove, irrespective of the size, we have to remove the entire nodes in all the stations.
Yes, sir.
Kanagvel sir is giving a close.
Sir, I think you are muted, sir. Kanagvel sir.
Yeah, I'm back. I got it. Professor Pranab sir and Professor Tiwari sir, your comments, please, sir, before we close.
Yes. So well covered, but one thing I would like to add for systemic metastatic workup, although that is lymphatic spread, PET CT scan is not available everywhere. Minimum investigation required is X-ray chest because lung is the site. So X-ray chest must be part and parcel of just like clinical examination. And USG neck, that should be supplemented with clinical examination for lymph node metastasis. So USG neck office procedure and X-ray chest, that should be a screening for systemic metastasis. This is my final remark.
So she presented well. We crossed her, but most of the questions are answered. I think she presented well.
Good presentation by Ashya. You are very confident, very composed. Little more narrowing, fine tuning of your clinical examination and presentation is needed. Otherwise, you are done extremely well.
Thank you, sir.
Akshata, I'd just like to add,
Yes, sir.
everything is fine, but please, honesty is very important as a surgeon, right?
Yes.
No, don't. Yeah, this is your examination. Don't look here and there. Don't seek help from someone sitting next to you. Okay. Otherwise, you're a good student. But that's one small thing marked everything.
Pranab sir, would you like to add something, sir? Professor Pranab sir.
Yeah. I think she presented very well. The case was also very good. A lot of findings were there, and workup she had a bit of problem, and at the same time, the staging, I think there's a mess up. Otherwise, she had done well.
Thank you, sir.
Dr. Akshita, would you like to ask any doubts to the national faculty here?
No, sir. I would like to thank.
I hope you definitely have studied a lot of things, and I'm sure you will have more questions. Okay. Kanna sir, can we move to the next case, sir?
Yeah, I think so, yeah.
Okay, sir. Okay. Thank you, Dr. Akshata. You can stay back for the discussion. You would like to ask something? I'm sorry if I stopped you.
No, sir. No, sir. I would like to thank for giving me the opportunity, sir. I would like to thank Dr. Gurushantappa sir for providing me this opportunity, sir.
Akshata, I just want
Akshata,
to make a comment here.
Sir?
Dr. Kanewal, can I speak for a minute?
Sir, definitely, sir. Please go ahead, sir. Please go ahead, sir.
You know, whenever you get a case of the oral cancer, and when you have to go for the reconstruction of that,
Yes, sir.
Never jump over the titanium plate first.
Yes, sir.
Okay. Reconstruction of the oral cavity, there are three things which you have to cover. One is the cover, another is the lining, and third is the support. So the titanium and all those things, they come as the last. First, you have to think about the cover. Cover means the skin.
Yes.
Second is the lining, that is the mucosa.
Mucosa.
So until unless you provide these two things, support can come later on. It can be as a secondary stage, it can come. So always you have to think about that, how you're going to provide the skin in that area. Any local flaps which are there, or the local regional flaps which are there, the rotation flaps which are there, and
Yes,
then
sir.
think about the distant flaps which are there. And then similarly also you have to think about the cover of that, the lining of that.
Yes,
So until unless you provide these two things, you cannot provide the support. Okay, if you're doing a microvascular, you can do the same things from the one source only. But if you're not doing that, then you can cover, give the skin and the lining at the first, and later on you can go for the support. Okay, so never jump over that you're giving the support first and you're not telling about the lining and the cover. Okay, right. Thank you.
Thank you, sir.
Thank you, sir. With the permission of the faculty, we now move on to the next case discussion. Dr. Akshita, you can stay with us for the next
Yes,
case
sir.
also. Dr. Naresh, please introduce yourself, your unit chief, head of the department, and start your presentation. Good luck to you. Dr. Naresh, do you have any challenges?
Kanagavel sir, it is good to have two head and neck cases today.
Yes, sir.
Because yesterday being World Head and Neck Cancer Awareness Day.
Sir, in fact, that was the reason, sir. Actually, I could not get, then I had to ask Jailal sir. Jailal sir is sitting in Kuala Lumpur, and then he arranged for the neck case, sir, because Dr. Gurushantapa sir gave last week itself, sir. This Dr. Akshata sent her presentation much earlier. The second one alone, I could not get. I had a neck because I could get all other cases. So I requested sir and his department colleagues helped us to get the case, sir. Naresh, are you with us?
Yes, sir. So I'm audible, sir.
You're audible, Kanay, but your slides are not in full screen mode.
Yes, sir.
Press F5. Yes, good luck to you. Please introduce yourself, your unit chief, your head of the department, and start your presentation.
I am Dr. Naresh. Good evening to all presenters. I am Dr. Naresh. My HOD is Dr. Jairal sir, and my chief is Dr. Selvin sir. I am from 3rd unit of Department of General Surgery, Kanyakumari Medical College. Sir. I am here to present on the case of a secondary neck, sir.
Go ahead.
The 60-year-old male, Mr. Mohan Raj, fisherman by occupation from Kolachala, came to the hospital with chief complaints of swelling over the left side of the neck for the past 3 months. Now, on going to the moving to the history of presenting illness, this patient came with the complaints of swelling for the left side of the neck for the past 3 months, which is insidious onset. Initially will only start as a small swelling and now develop to attain the present size of its own. There is no aggravating or relieving factors on this, and there is no evidence of discharge from the swelling. There is no associated fever. The swelling is not associated with any pain or fever, and there is no increase in salivation or in size during salivation or during meals. On examining other than the swelling, there is no history of any painful ulcers in the oral cavity. There's no history of any difficulty in speech. There's no change of voice, and there's no refer to pain or hearing, and there is no history of dysphagia. There is no history of evening rise of temperature, and no history of loss of weight and loss of appetite, and there is no history of any previous trauma. Past history. The past history is that it's not a known case of any diabetes mellitus, hypertension, tuberculosis, asthma, and epilepsy, and there is no any history of previous irritation to head and neck. Personally, she is not a tobacco choker, but is alcoholic for the past 40 years, and he's a smoker for the past 30 years. Smokes 10 BDs per day. In family history also is not significant. On general examination, the patient is conscious, oriented to time. It's afebrile, it's not para, it's not ectric, there's no sinus and clubbing, and there's no generalized lymphadenopathy. Vitals, blood pressure is measured in sitting position in the right brachial artery at measured at 130/80 millimeter of mercury, and pulse rate is 80 beats per minute, which is regular. Local examination on inspection, patient examined in sitting posture and examined from front. The single swelling of size 6/4 centimeter is noted of the left side of the neck and the lateral aspect. It's a well-defined border and surface appears smooth on inspection. There is no calf muscles or swelling or skin or swelling is normal, and there is no other swellings in the neck. Moving into the palpation, there is no local rise of temperature. It's not tender. There's a single swelling of size 7/4 centimeter. It's noted over the left side on the neck, on the lateral aspect of the neck. The surface is nodular, it's hard in consistency, it's non-mobile. The skin over the swelling is not pinchable. There's no transmitted pulse over the swelling. Then the examination of oral cavity, there is presence of dental caries without any evidence of ulcers over the oral cavity. The examination of cranial nerves were normal and other groups of nodes were normal. This is the clinical pictures showing the swelling of the left lateral side of the neck. And this is the FNAC picture of the patient, which suggests of metastatic carcinomatous common cell deposits. Then going to other system examinations, then systemic examination as serious as S1, S2, and there's no murmurs. In respiratory system, there's no bilateral laryngeal, there's no added sounds. Parabrine is soft, there's no adenomegaly, and PR also is a normal findings. So I'm going to summarize a 60-year-old male who's presented with swelling of the left side of the neck, the lateral aspect, which incidence onset, which is painless and not associated with any other symptoms. The swelling showing nodular surface and hard in consistency and fixed.
Naresh, why did you show the FNAC in your examination?
We did an FNAC, sir. We had it wrongly, sir.
It will not come in the examination part.
Nice. Okay, sir.
Right. So, what is the difference? Don't go over the FNAC finding here.
Yes, sir.
Just let us keep only clinical one.
Okay.
So you say it's the lateral side of the neck. What is that lateral side of the neck? What do you understand by that? What
So
is the
we are going to the lateral side of the neck. We on the examination of lymph nodes, we are going to check for the level 2 and 3 and 4 lymph nodes. Level 2, 3 lymph nodes, sir.
Now, what is the lateral neck? I want to know here. What is lateral neck?
So lateral neck.
Okay, tell what are the parts of the neck?
So parts of neck, lateral neck, it's compresses over the region of sternocleidomastoid muscles, sir. With the level 2, 3 lymph nodes.
Tell what is anterior triangle, what is posterior triangle, and what is the nape of the neck?
Sir, anterior triangle comprises submental and submandibular triangle, sir. Posterior triangle, which is
Tell the boundaries of the anterior triangle.
Sir, submental triangles, upper part is from hyoid bone, sir. Lower part is bound by muscles.
Bone. Anterior triangle.
No, mistaken.
From the hyoid bone? Upper border of the neck? Of the anterior triangle?
Posterior triangle is formed
what is the
between
submandibular part? That is not the part of the neck?
Yes, sir.
So what is the upper border? What is the medial border and what is the lateral border of the anterior triangle of the neck?
So anterior triangle of the neck.
Yes.
Such a medial border is. I am not too sure, sir, but study, sir.
The midline, you know?
Yes,
Midline is the medial border, upper border is the lower border of the mandible, and lateral border is anterior part of the sternocleidomastoid.
Yes, sir.
Anterior margin of sternocleidomastoid. And what is the posterior triangle?
Posterior triangle is formed between the anterior border of sternocleidomastoid, sir, and the lateral border of trapezius muscle, sir.
And lower border?
So lower border is
posterior triangle?
trapezius muscle and lower border is
lower border of the triangle, posterior triangle. Sorry, asking.
specifically The big
clavicle, no?
Clavicle. Superior margin of the border of the clavicle. That's the lower border of the posterior triangle.
Yes, sir. Clavicle.
Yeah. So what is there which is behind the sternocleidomastoid? You know, sternocleidomastoid is a wide muscle. Where does it go? Does it go to the anterior triangle or does it go to the posterior triangle?
The posterior border is formed by the posterior border of sternocleidomastoid muscle, sir.
So that you have already told. What sir is asking is the contents behind the sternomastoid, deep to the sternomastoid, belongs to anterior triangle or posterior triangle?
Posterior triangle. The suboccipital nodes and the...
No. The sternomastoid muscle is a big muscle, bulky muscle. There are structures deep to the muscle. So those structures belong to anterior triangle or posterior triangle? You told the anterior triangle's posterior margin is the posterior border of the sternocleidomastoid.
Then it confirms the anterior triangle.
Yes, that's what sir was asking.
No, because you have written here swelling over left side of the neck in the lateral aspect. You know? So as such, there is nothing like the lateral aspect. But in fact, the structures which are below the sternocleidomastoid, you may think that it is the lateral aspect. You know?
Yes, sir. Okay.
Right? Okay.
Okay.
So now tell what are the differential diagnoses of the swelling in this area?
Yes, sir. First, I go with the tuberculous lymphadenitis, sir.
Okay.
Second,
what is the age of this patient?
60 years old male, sir. Chronic smoker, sir.
So do you think 60 years is a good age for the tuberculosis?
It's not a good age, sir. It's old age.
Yeah.
Yes, sir.
Usually it occurs in the younger patients, no?
Yes, sir.
Right. Okay. Okay. Tell other differential diagnosis.
Sir, sir, normal cervical lymph node enlargement, lymphadenitis, sir.
Okay.
Maybe a lymphadenitis. It may be a carotid body tumor also, sir.
Okay.
Site where.
Okay. So if it is, let us take it is a carotid body tumor. What is the sign for the carotid body tumor? If the swelling in the carotid triangle is there, what is the typical sign there?
So it's Bryce sign, sir.
Bad is sign? No. Bad is for, you know, when you're talking about the thyroids.
Yes, it will be soft, sir. The swelling will be soft.
No, carotid body is not soft.
Yes.
Carotid body is not soft. And even it may not be pulsatile also.
Yes, but there we can find out the transmitted pulsation from carotid artery in case of carotid body tumor, sir.
What is the movement of the swelling in the carotid triangle which can decide is it a carotid body tumor or not?
The soft fluctuancy, sir. Fluctuant swelling, sir.
No.
Or bilobed swelling.
It can move only in the transverse direction, but not in the vertical direction.
Yes, sir. Yes, sir.
Okay, if the swelling in the carotid triangle is there, then one differential diagnosis can be carotid body tumor. What will the other differential diagnosis in the same, if you think? What structure is there which is just behind the carotid artery?
In jugular vein, jugular vein.
Okay, jugular vein. Any nerve there?
So,
any nerve in the same area?
Spineless nerve.
No. In the carotid sheath, what is the third
facial nerve?
Facial nerve? No. It is not the facial.
Listen to the question. Listen to the question and then answer.
Yes.
Structures in the carotid sheath. Carotid artery is there, internal jugular vein is there, and which nerve is there? Which is the 10th nerve?
Vagus, sir.
Yeah, vagus nerve is there. You know? So you can have a paraganglioma arising from the vagus nerve.
Oh, yes, sir.
Okay, so these are the two structures, two differential diagnoses in a swelling of the carotid triangle that will move only transversely but not vertically.
Yes, sir.
Okay. Why it is not a branchial cyst?
Sir, first in case it's a patient age is 60-year-old, sir. Branchial cysts and persistence of second, third cleft is congenital, sir. Second, it's branchial cyst will be, the consistency will be soft and smooth or smooth surface, sir.
Okay. Now, can you tell what are the various hard swelling in the lower part of the neck? Hard swelling in the lower part of the neck.
Hard swelling, sir.
Yeah. Apart from the secondaries, which can be hard in consistency,
Yes, sir.
which other structure or diagnosis can be there of a hard swelling in that area?
Then tuberculous adenitis with maybe hard, sir.
Okay, if it is calcified, agreed.
Calcified.
Yes.
Sir. Second is
Any bony structure in the area which can come?
sir. No, sir. Don't.
Sir has already given the clue.
Bony structures around.
Yeah, bony structure. What bones are there in the lower part of the neck?
Clavicle, sir.
Clavicle just
So,
above.
vertebral. Any cartilages?
Any extra
cartilages?
rib? You know any extra rib?
Cervical rib, sir.
So which type of the cervical rib will give a hard swelling?
Sir?
Which type of the cervical rib will give a hard swelling in that area? You know what are the various types of cervical ribs?
No, sir.
So when there's a bony protrusion is there, no, it can be just a fibrous one, it can be a combination of that, or it can be the bony. So sometimes there's a bony globule is there in that area, which will present like a hard swelling in that.
Okay, sir.
Okay.
Okay, so now what do you think this is? You've got a lump in the neck and nothing in the aerodigestive system. So what do you think this is?
Sir,
What is
it's
it clinically called?
yes, sir. Yes, sir. It's a hard nodal, sir. Hard lump, sir, with nodular
That you've
surface.
shown it with the FNAC. You've given us the FNAC report already. So what do you think?
Then I
what do you
think
call
that
this condition?
Yes, sir. We couldn't found a primary lesion, primary, sir. Here I could see that the secondary node, it's a node of secondary metastasis, sir. We couldn't find a primary lesion here, sir. So it may be in secondary metastasis.
So what is this called?
Sir?
What is this condition called?
The second is neck with occult primary, sir. Second is neck with occult primary.
Occult primary. Okay. Okay. You think it's an occult primary? Why? What is clinically undetected primary? What is cup?
Sir, if the primary is undetected and clinically,
what is the difference between? So,
sir, if it is not
cup and occult primary, what is the difference between cup and occult primary?
In unknown primary, with also radiological investigations and other investigations, we couldn't find the primary, means unknown primary, sir.
Okay, then what is occult primary then?
Sir, in clinical findings, we couldn't find the.
Look, there are two things. One, yes, clinically you can't detect the primary, and you got lymph nodes with secondaries.
Secondaries,
right?
Yes, sir.
And the second is you have got occult primary. In spite of your best tools, you cannot detect the primary.
Yes, sir.
So that is occult primary, right? So why does an occult primary happen?
So when the primary couldn't be identified, sir.
Why can't you identify the primary? Why? How come you're getting a secondaries without getting the primary? What has happened to the primary?
Sir, when the primary size is very low, it cannot be identified in investigations, sir.
Okay, could be that it's microscopic, but more important, can it be that the primaries are very aggressive? So it's gone to the lymph nodes, but the primaries have not showed up.
Yes, sir.
Right?
Okay.
Or that the primary has regressed while the secondaries have persisted.
Okay, sir.
Right?
Yes,
or
sir.
there is primary from distant.
Yes, sir.
Right? Okay, so now you suppose it's clinically undetected. What will you do now? Secondaries, FNAC shows secondaries. Now how will you look for the primary?
Yes, sir. Sir, first we are proceeding with the pan endoscopic methods, sir. In case
What
of
is pan endoscopy?
It comprises of esophagoscopy, sir, bronchoscopy and duodenoscopy, sir.
And esophagoscopy,
bronchoscopy and duodenoscopy.
So esophagoscopy is different from duodenoscopy.
So esophagoscopy, bronchoscopy and
nasopharyngolaryngoscopy.
Uvidoscopy, yes, sir.
Right. Okay, you've done that. Then what? You don't find anything. Then what do you do?
Yes, sir. We did an opinion, sir, but that's normal finding in both.
Yeah. So what do you do then?
So next
While
we will
doing
proceed.
this, what do you do?
Next we will proceed with
what is surveillance biopsy?
It's a blind biopsy. So blind biopsy, sir. It gives us some ideas about 15% of unknown lesions, sir. Brain biopsy is taken from fossa of Rosenmuller, sir. Lower tonsil bed, sir. Lateral bar of tonsil, sir. Pyriform fossa, sir. In 15% of cases, we could get the result. This is surveillance biopsy, sir.
And subglottic larynx.
Subglottic larynx.
What have you found? Is the lymph node in the upper half of the neck or in the lower half of the neck?
Upper half of the neck, sir.
Or is it the mid neck?
Yes, sir.
Upper half. So most commonly secondaries in the upper half of the neck will come from where?
It mostly commonly comes from nasopharynx, oropharynx area, sir.
Okay, it can come from the oral cavity, nasal pharynx. What about salivary glands?
Yes, sir.
So
maybe from submandibular glands, sir.
Not parotids? Look, yes, you have to know the drainage area of this. What is the drainage area of these lymph nodes?
So level 2, we can upper limits is mostly of any oropharynx, nasopharynx, and salivary glands, sir. In case of middle deep sublunar 3 and 4, we could get deposits from.
No, hang on. What about the scalp? What about the scalp? Did you check for
when scalp is involved with posterior nodes may be involved in skin, sir. In case of scalp, we could get a posterior group of nodes.
Maybe, but it can still. So have you examined the scalp? Have you examined all the drainage area?
So we examined other areas of node drainage. We couldn't find any lymph node drainage in other areas.
So in your examination, you have to mention the drainage area that you have examined the drainage. Right? Okay. What about the lower half of the neck lymph nodes? Where do the secondaries come from? From there. Where do they come from?
So in lower part, it also involves the sites of so in addition to the oropharynx, nasopharynx, and the thyroid and larynx, sir. We could get from upper part of esophagus, sir, and left in the supraclavicular lymph node. We could suspect others from GIT, breast, sir.
What about thyroid?
Thyroid, we can get the lateral node fully, sir. T3, then 2 to 4 lymph node, 2, 3, 4.
Look, hang on. Even right. No, you have to examine all these areas. You have to examine the abdominal cavity carefully. Yes. There can be secondaries from these areas also, right? So your examination and your history is quite incomplete because you have not taken any negative history for these areas.
Yes, sir. Yes, sir. We should add a no history of abdominal pain, hemoptysis, and all.
Naresh, how does the FNAC help you to chase the primary?
Yes, sir. In FNAC, we have got that is a metastatic deposits, and it involves it involves the origin of squamous cells, sir. Mostly 80% of.
Suppose it said adeno. Sorry. Suppose it said adeno.
Yes, sir.
It be adeno.
Yes, sir. It could be
Then
adeno,
where
sir.
would the primary come from?
So in
Where would you look
adeno,
for the primary?
so I will check for X-ray chest and CT chest to rule out the bronchogenic carcinoma, so lung tumor, lung carcinoma, sir, mainly in case of adenocarcinoma.
What about breast?
Yes.
What about
breast.
stomach?
Yes, sir. We should check the GIT organs, sir.
What about GI? Right.
Yes, sir.
What about
Other
pancreas?
organs. Yes, sir.
They all can be give
Adenocarcinoma.
rise.
Yes, sir.
So in
It's
this case, FNAC has been done. It has come out with squamous cell carcinoma, isn't it?
Yes, sir. Yes, sir.
Okay. So then what further investigations you carried out in this patient?
So we looked for VDL scopy and digital endoscopy, sir. It was found to be normal, sir. So we are subjecting patient to CCT neck, sir, to find out any lesions over the other areas, sir. After CCT neck, we will proceed.
Have you done the CT neck in this patient?
No, yes, sir. We are awaiting the reports here, sir.
Okay. Now, what investigations in this patient may be diagnostic for finding out the primary here?
I think we can do a PET CT, sir.
Yes. In fact, this is the place where the PET scan has got the most importance.
Yes.
Okay.
Yes.
To find out that where is the primary here.
Primary.
Otherwise, PET scan is usually done for the follow-up to find out the patient has got the metastasis or not. But here it is that you will do the PET scan in this patient to find out that where is the primary is there. And that can be very helpful. Okay. Even after the PET scan, you do not find a primary. Then how will you proceed?
Sir, if the primary is not identified, sir, even in case of an FNAC also, sir, the node, we can go for an open biopsy of the node followed by node dissection, sir.
How the open biopsy is going to help you?
Sir, not like helping, so we couldn't find the we will do a frozen section and we will do an earlier radical node dissection for the patient. When we couldn't identify the second primary, sir.
So why can't you directly go based on this for the modified radical neck dissection? Why you just want to do a biopsy and then confirm and then go for that? Is he a candidate for that? To go for a modified radical neck dissection?
No, sir. I think this patient needs a radical node dissection as it's a fixed node with more than size of 7 centimeters, sir. It goes for N3, sir. So it's not advisable to do a modified radical neck dissection in this patient, sir. So we can go for a radical node dissection.
Okay.
Before going to that, sir, it's a fixed node, sir. So we can subject this patient to radiotherapy to down to this disease, sir. Then followed by radical node dissection, sir.
Okay, so you are planning in this patient to go for the radical neck dissection.
Yes, sir. Before
what is the difference between a radical neck dissection on the left side and the right side? Okay, your patient has the disease on the left side.
Left side, yes, sir.
So what is the difference between a radical neck dissection of the left side and the right side?
Left side, right side, no, sir. Maybe in jugular vein components.
What extra thing you are going to encounter on the left side, which is usually not on the right side? And that can cause a big complication. Look, in the post-operative period, the white color fluid is coming out.
So lymphatic duct damage to duct, sir.
What is there on the left side then? Which you are likely to damage when you're doing a radical neck dissection?
Thoracic duct damage, sir.
Yes. Yeah, that is
Okay.
the main difference.
So may I just ask a question, sir?
Yeah.
Doctor, why can't you do an open biopsy? Why is it not done? You said you asked about an open biopsy.
Yes, sir. Yes, sir. First, it may rupture the subfacial features to, and there may it cause lead to a spread of tumor, sir. When there is subfacial components breached, sir, in case of open biopsy directly, it may cause weeping, sir. So we could avoid open biopsy to extend for this one.
So now there is one thing called that you've done everything and you couldn't find the primary. Is there any other place where anything else you can do before you go in for surgery? Any other biopsy which you can do? Or any other procedure which you can do? Surgical procedure?
It's surgical procedure.
Ipsilateral tonsillectomy.
Ipsilateral tonsillectomy, sir. Ipsilateral tonsillectomy.
You have to do that, right?
Yes, sir. Ipsilateral tonsillectomy.
Okay. So now what will you go for this patient?
Yeah.
Is the patient operable or not operable?
It's a non-resectable, so it's a firm and it's fixed fixed swelling, sir. Comes in the N3, sir. So first I will go in pre-op radiotherapy, sir, to down the disease and make it mobile and followed by radical necrosis.
So which areas will you give radiotherapy to? What are the areas where will you give radiotherapy to?
Then over the nodal regions, sir.
No, does the patient fall in the favorable group or unfavorable group?
Favorable group, no, sir. Can't understand, sir. Favorable. The old age, 60-year-old males, sir.
More than 6 centimeters and 3 fixed lymph nodes, you will do a chemoradiography.
Yes, sir.
Right? In favorable group, you'll go for a external beam for radiotherapy or radical neck dissection.
Yes, sir.
Okay. So
the complications of the radical neck dissection. We have discussed about what are the structures removed in that in the last presentation. So tell what are the complications of the radical neck dissection.
Sir, we could get a jugular vein thrombosis here, sir. With bleeding, we can get a hemothorax, sir. There may be symbolic chain involvement with damage, sir. It's on a syndrome, sir.
What is carotid blowout?
Sir?
What is carotid blowout? Carotid blowout. Have you heard about carotid blowout or not?
Yes, no. Yes, sir, but not coming to mind, sir.
Carotid blowout means the carotid will blow out and the patient will die in front of you. So you have to prevent that. So how can you prevent? Like in the case of the inguinal blowout dissection, there can be femoral blowout. Okay. So for prevention of that, these blowouts, what precautions can be done?
The careful dissection when we made, sir.
The careful dissection has to be done. That is the surgeon's choice, that you have to do a careful dissection. But how you are going to prevent that? You know, what are the common types of flaps which are used for the neck dissection?
Flaps, sir.
Yeah.
Please, sir.
Have you heard any names for that? Kreis flaps, Hayes-Martin flap.
Yes.
2 flaps, 3 flaps, 4 flaps.
Yes, sir. We should make an arterial supply to this flaps to prevent the necrosis.
Okay, the main reason for these blowouts which is there is the flap necrosis the infection and bearing of the carotid vessels. Okay, so you have to prevent all these things. That your flap should be good, especially if you are using like the 4-flap technique, what is called the Hayes-Martin technique, which is there. Your angle should lie at a different plane than the lying over the carotids. So you should make your flap like that the angles which are there, because angles, they get necrosed. And once the necrosis is there, infection is there. So you have to plan your flaps like that. You have to prevent the necrosis of the flap so that your flaps should be thicker rather than very thin flaps. You have to prevent the infection of that. And then if your carotid has been exposed completely, okay, then in that case, you have to cover those carotids. So how can you cover the carotids? By which muscle you can cover the carotid? Like if it is a femoral vessel is there, which muscle is used to cover the femorals? You can use the sartorius muscle there. In the femorals, you use the sartorius muscle, while here you can use the what you call the levator scapulae muscle, which is there. So you can bring this levator. You cannot use the sternocleidomastoid because that has been removed.
Yeah, taken already.
Okay, that has already been taken out. So you have to use the levator scapulae for that. But in case if you are preserve the sternocleidomastoid, you can cover by that also.
Yes, sir.
But if it is not there, then you use the levator scapulae muscle.
Levator scapulae muscle.
All right. Okay. So what are the various nerves which are removed when you are doing a radical neck dissection?
Spinal lacery nerve, sir.
Yes. Any other nerves which are removed? You should try to preserve that, but many times they are removed. So use the C3, C4.
Vagus.
Vagus you never remove. Okay. Never remove the vagus.
Spinal lacery nerve.
C3, C4. Cervical sympathetic chain which is there, you can remove few branches, but even those should be preserved. What muscles are removed?
The sternocleidomastoid muscle, sir.
And any other muscle which is removed?
It's omohyoid. Omohyoid muscles.
Omohyoid muscle can be removed. Yes. Omohyoid. And what are the glands you remove?
The submandibular gland, sir.
Yes. Submandibular, submental, and the tail of the parotid. Tail of the parotid.
Base of the parotid.
Right.
Tail of the parotid, yes, sir.
Okay. So if you damage the spinal accessory nerve, what happens? What are the muscles which are supplied by the spinal accessory nerve?
Spinal lacery nerve, we get to sir, the shrugging of shoulder will be lost, sir.
Which muscles it supplies?
Sir?
Which muscles are supplied by the spinal accessory nerve?
The latissimus dorsal.
Spinal accessory.
And the trapezius. Okay, that is why if you excise the spinal accessory nerve, the patient will have the problem with the shoulder movements, shrugging of that which will be there.
Yes.
Yeah. What happens if you damage the hypoglossal nerve in dissection? Hypoglossal nerve can come also, and if you damage that, what can happen?
Sir, I couldn't hear, sir.
So
I couldn't hear, sir. What, sir?
Anything happening to the tongue?
So in hypoglossal nerve damage, sir, we get movement of tongue disability, sir. So movement to the deviation to the same side on the tongue. We should check for that also, sir.
Right. Okay. Dr. Shah, you want to ask anything?
I'm fine, sir. I think we can close it off. So can we wind up, sir?
Professor Tiwari,
Yes.
sir.
Yeah, Dr. Tiwari.
Yes.
Yeah.
So just in history, so many points you have missed. You did not mention about hemoptysis, epistaxis, that are quite important. Because if there is a neck swelling, first thing should be whether it is in upper part of the neck or in the lower part of the neck. But right from the history till the examination, you just focused about left side lateral neck swelling. So that is important. You must mention about whether it is upper neck or lower neck.
Yes.
And if there is unknown primary and neck swelling is present, remember just 4 things. Whole body PET CT scan, that comes in a big way. And second is MRI. And third is pan endoscopy. Pan endoscopy easily available everywhere. So probably that is the first thing we can go. Pan endoscopy, MRI, whole body PET CT scan, and tonsillectomy. That was mentioned in the middle of the discussion. That is also important, part of detecting primary. But nowadays, if facility is available, tonsillectomy along with robotic assisted base of tongue mucosectomy, that should be done. So these are 4 points in detecting the primary. So in history and in investigation, to detect primary, these are important things. Otherwise, you have worked hard, but you need a little bit more work. Thank you all.
Thank you.
Professor Karnakaran, sir.
Naresh,
Sir, good evening.
if it is a lymphoma, what is B symptom and what is A symptom?
Naresh, would you like to answer to that?
Sir,
You know, are you audible?
no, sir.
Are you able to hear my question? If it is a Hodgkin's
No, sir.
lymphoma, it is not audible.
Yes, sir.
Are you able to hear us, Dr. Naresh?
So no, sir. Am I audible, sir?
You are perfectly audible. Looks like you are answering to my questions. Am I audible at all?
Sir, yes, sir. But Karnan sir voice is not audible, sir.
Okay, sir. You please, sir wants to know about heart. Please go ahead with your question, sir. Professor Karnakaran, sir.
See, if the lymph node
Yes,
is
sir. Yes, sir.
Hodgkin's lymphoma,
Yes, sir.
what is A symptom and what is B symptom?
A symptom and B symptom, sir.
Yes.
I didn't read about something. I couldn't remind that, sir.
So B symptoms are fever more than 38 degrees Celsius, loss of weight more than 10%, and drenching night sweat. These
Yes,
three forms the B symptoms.
Yes,
And
sir.
A symptom is nothing but absence of all these three.
Okay.
A symptom means
Fever, loss of-
none of the three is present.
Yes.
B symptoms means one among the three, or two among the three, or all the three may be present. That is B symptom.
Yes, sir.
B symptoms literally means the disease has become systemic. Okay.
Yes, sir. Okay. I'll not forget, sir.
So may I just say a few things?
Please, sir. Please,
Naresh,
sir.
Yes,
Dr. Naresh, look, in a
Yes,
case
sir.
of unknown primary, you have to find out whether by any means, whether you can do the primary or not. Sometimes the primary is not found. You must find out whether the lymph nodes are in the upper portion of the neck, middle portion of the neck, or the lower portion of the neck. You must find out whether the secondaries are squamous cell or adenocarcinoma. right? And you have to look for the primary by taking history of all the areas which can go to the neck.
Yes.
Which can metastasize to the neck, right? Including melanomas. So it's a top to head to toe examination and a very detailed history,
Yes.
right? Which was missing in your case.
Yes.
Sir, actually, I have to put on record, he was given very little time, sir. Because
okay. That's fine. I mean, this is for everyone.
No, sir, these comments are definitely...
I've attended classes with CUP, and they tend to miss out on the limbs. They tend to miss out on the testes. They tend to miss out on the breast, the upper aerodigestive system. So that's important.
One last question, Dr. Naresh. If all has been done, you're not able to locate a primary, what is the current recommendation for unknown primary of the next secondary treatment, NCCN guideline? How do you treat the unknown primary neck?
Based on size, we will check out whether its previous art should be given, followed by radical node dissection, sir.
Okay, so can you segregate into two things? When do you give like empirical chemotherapy? When do you consider surgery for this? Have you read the recommendation recently?
No, I've studied only the treatment for each stage only, so not the recent.
Okay. So there have been very clear recommendations given by NCCN when to start chemotherapy, what type of combination you want to go for, platinum base or what, and then you also has to understand there are immunohistochemistry from the node, so that could exclude possible primary. At least you know you are dealing with a squamous primary or adeno primary, so that helps you to channelize your chemotherapy. Radiation therapy is added if there is a squamous component of it. So these are the things you should have, because this is recently it was asked in our state, a long question, right? A question of how do you manage secondary neck of an unknown primary was a long question. I wish you go take time to Devita gives a wonderful description of how to handle it. Runs to few pages rather handling this. Wish go back to read Devita. And then number 2, you should read up the NCCN guidelines. These two will form the basis of answering. Students watching should also be knowing this will be a very favorite question for your examiner if there is any neck case. So I wish all of you spend time reading about it rather than going. See, of course, you will focus on CA tongue, you will focus on CA buccal mucosa, everything you will focus. But it's unknown, to write a long question, one should be better prepared. I wish go back all of you to read up all those things and probably make your notes of all these important things. Especially the OSCE also, there was a question of unknown primary. Be prepared to handle that. All right. Dr. Naresh, would you like to ask any doubts to the faculty here?
No.
Professor Ibrahim, sir, are you with us? Okay. I think sir is no more with us. Kanna sir and Tiwari sir, Karnakaran sir, can we call a close, sir?
Sir, I'm here. I was listening to. But it was a very good presentation. Yes, sir. It was very good presentation. Only thing is, Naresh has to spend some extra time in basics like anatomy, because surgery is nothing without anatomy. So Naresh, it was a good presentation, but you have to improve your things in anatomy alone. And most of the time, this secondary neck will come as a short case, so the discussion can go anytime in anywhere, and also presentation may not be in the same manner. You may be going for a retrograde presentation, like from diagnosis you may go. And actually, there was a discussion about lymph node biopsy. So Karnakaran sir was also asking about lymph node biopsy and lymphoma. So lymph node biopsy is indicated only in lymphomas, because with FNAC we cannot come to a diagnosis in lymphomas. So lymph node biopsy in an neck node is indicated in case of lymphomas. So that you have to keep it in mind. And also, I don't know whether you have presented the nodes in other areas like inguinal axillary. So that is not being mentioned or presented, I guess. So that is also very important.
Sir.
Whenever you see a node, the other nodal areas are also has to be explained in
Yes,
detail.
I added that.
Yeah, some extra points I'm adding.
Yes.
Sir. Thank you, Danesh. With the permission of the faculty, we call this session a close. Professor Tiwari, sir, and others, if any one of your students would want to present a case, please reach out to me. We'll be glad to have them on board. And friends, next week we are going to have a vascular session because like we are trying to channelize now because exams are on, and I think most of the centers have already finished the exams. Now we have to concentrate on presently the second years. Probably we have to cut down the management questions and deal with more of clinical examination and basics. And still the first years have not been allotted. So I think another few weeks we will go on a basic mode. And then once the students mature enough, then we'll step up to the higher mode. Once again, students, a kind reminder, apply for the NEET super specialty. Please get into one super specialty of your choice. Another 3 months of hard work. Don't relax after your MS exam or DNB exam. Wish all of you could spend serious effort and get into a NEET super specialty because things are changing by the year, rules are changing by the year. So let us not take this coming 2-3 months light and concentrate on preparation for exams. It is only a general paper. So basic sciences paper and specialty paper for general surgery only. So it is definitely worthwhile because it's going to be an extended revision alone. So on behalf of all the faculty, we wish you all the best for those who are going to give exam, and we congratulate for many students who have already done well in the exam. And we look forward for yet another Friday class. Thank you, friends. On behalf of all the faculty, we wish you good night and good luck. Thank you very much.
Good night.
Good night, sir.
Sir.
Good night. Good night.
Good night.